It's my absolute pleasure to be here today with Professor Judy Hung. Judy, welcome. You are a bit of a legend over here. Consultant cardiologist, director of the Echo Lab at Mass General, director of clinical research, and I'm particularly interested to know that you're a professor of clinical medicine at Harvard Medical School, which is right up my alley, and of course president of the ASE in 2020. You are, of course, coming to our conference, which we're really excited about. And I get 15 minutes to talk to you beforehand, so I'm really excited about this. First question I wanted to talk to you, just to start the conversation off really, is really about one of your guidelines of which you co-authored, which is obviously the MR decision-making pathway, a really big one. I am so interested in the fact that you've put imaging next to clinical examination, and you have really championed that in your guideline. There's a big difference, isn't there, between the way medicine's practiced across the world, but what do you think about the importance of clinical examination sitting next to further tests, echo of course being the first of those? Where does it sit? Why is it important?
Sure. No, thanks, Claire. And first of all, I'm so looking forward to attending the meeting in October, and thank you for spending a few minutes with me to talk about echo related topics. But I think in regard to that question, it's in a way I trained in a different system where we all to be cardiologists, we all undergo either 2 or 3 years of general internal medicine training. And I do think, and it may be a bias of my own training, I do think it's important to have some general medicine training. It's, and the reason is I think it makes you a better cardiologist. One of the main symptoms we have to deal with is dyspnea. But dyspnea can be caused by so many other conditions other than cardiology, and it's important to be aware of that. And I think that general medicine training helps you, with your differential diagnosis.
Absolutely. I completely agree with that, and I think our training program has just reinserted a year of general medicine into training for cardiologists, which I think is a step.
Oh, have you?
Yeah, which I think is a step in the right direction, actually. It makes me think of Mackenzie, Sir James Mackenzie, who of course was the man for whom the American Cardiology Society was, College of Cardiology was set up for. And he was an absolute advocate of clinical examination, and he predicted the future. And he said, be really careful that you don't get too narrow in your practice. And he's 70 years on, no, 100 years on, he's absolutely spot on, isn't he? Totally spot on. Unless we have that breadth, we miss stuff. So I'm really interested to hear that. Is that
well, sorry to interrupt. I think one of the things is that, imaging is such a powerful tool, powerful diagnostic tool, but it has to be integrated with the patient. And the clinical exam and sort of the general knowledge of how the patient's presenting. So I think that's where it's important to say it's not just imaging, but it's the integration of imaging with the patient clinical presentation.
Yeah, I mean that's actually such a broad statement, because of course in this country, and I don't know how it works in America, and I'd be interested to hear actually, Judy, echocardiographers, I hope now just means someone who uses echo clinically. That's, I hope, my legacy. And that then you have to find out whether they're a scientist or a medic by background. But actually, we all need to have that clinical knowledge and acumen, no matter what our background. So in America, how independent are echocardiographers? How are they independent? Do they run their own clinics? How does it work?
Yeah, so I think the term echocardiographer is generally referred to in America as a cardiologist that specializes in echo. If so, it's a broad term, perhaps, and it doesn't necessarily mean a specialty designation, although we do certainly have that with our national board exam and echo that a lot of cardiologists take. So,
And do you have independent non-medical echocardiographers who are echoing separately to the medics?
yes, okay, so I think that's where I'm getting at. So we have a different system than I think the exercise physiologists who you're referring to as echocardiographers, who are I think more independent, absolutely. And so we have sonographers, but they are more viewed as, obtaining the images, and the interpretation is performed by the physicians.
Right.
And they're not, so our sonographers are not, that don't have, I believe, the independence as you have with exercise physiologists.
Right.
But they function in a very, very similar way. I mean, they obviously aren't just getting the images. They're trained to also understand what they're imaging, and how to and interpreting, essentially. Although, as I said, the physicians here ultimately sign off on the interpretations.
Okay, so there's a
There isn't
degree.
that independence.
No, no.
No, and I think that's just been our system for a variety of reasons. I mean, that's just sort of how the training was established. And that's just been our workflow.
Mm. And is there an appetite for them to be more independent from there?
Yeah, yeah. I think you're bringing up a topic that has undergone a lot of discussion about whether sonographers can essentially independently interpret the studies, which I believe is what exercise physiologists do. I think the issues, I certainly think they can, and I think the issues are uh, definition of scope of practice, and then there are issues about, at least in our system, the medical legal issues of that, and also, frankly, the reimbursement issues.
Mm.
So because we have sort of very different systems that way, I'm not sure they'll ever become fully independent. But I'm hoping that it will, there'll be a system where there'll be at least a preliminary interpretation that will be by a sonographer that will be accepted. And then, the physician will do more supervisory type of interpretation. But we're not quite there yet.
No. I bet there is an appetite there, because what we found amongst our workforce is that if you allow people to develop, they stay in the profession, because actually what people want, not just to be well paid, reasonably paid, but have good conditions, is to develop as humans and practitioners. It's quite interesting that I think it speaks volumes about people, that all they want to do is have the opportunity to develop.
I,
We have,
you're absolutely right on. I mean, I think it's about job satisfaction, and the independence of that will add to that. I think it's a good goal, and it's definitely doable. It's just there's so many other issues with our system right now that we have to sort of get through that process of,
yeah.
all the other issues that I brought up.
Speaking of issues, we have issues here. One of our major issues is our backlog of tests from COVID, not just from COVID, but also because we've got, echo is the linchpin test, isn't it, for so many specialties at the front door of a hospital. Echo just goes from strength to strength in what it can do for patients. And obviously my particular practice is in critical care, and I can't believe the development that has happened in that specialty in 10 years, really. It's now essential. It's not optional, it's essential. Do you have waiting list issues in America? How does it work there?
Yeah, we have a significant workforce issue with just finding enough sonographers. Um, that's been our issue, and that's led to wait lists across the country. I think it was magnified by COVID, where a lot of folks decided to retire early or decided to just leave the profession. And it's getting better, but we will have a chronic shortage, and I actually predict that there will be a chronic shortage for years to come, because echo has become the primary and forefront imaging modality, and it's so valuable. I actually think that we're somewhat limited because we need to provide better access to patients getting this modality, and we don't often have enough sonographers and physician staff to be able to deploy it. So I think we have to address that. And my hope is that eventually to limit or to resolve the wait lists, we need to get more efficient. And a big part of that improvement in efficiency will be machine learning, the application of machine learning, because it's a wonderful modality, and it's clear to me anyway that we need to provide better access for it.
Well, let's go where you've taken the conversation, Judy, because we've got a big debate going on at the end of our conference about AI and where this is going to fit into practice. Go on then, predict the future for me. Where do you think it's going to end up?
Yeah, no, and first of all, the conference, I want to congratulate you on a wonderful conference, comprehensive, and just packed in just 2 days. And one of the session that you mentioned in Saturday afternoon, I'm looking forward to attending. Absolutely. So I think machine learning will be transformative for medicine, but also especially for echo, because machine learning is well adapted to improve efficiencies in imaging. And so I think a lot of folks have a fear, understandably, of machine learning, that it's basically going to take over my job, and but I think in fact what's going to happen is going to allow us to be more efficient, and we will be likely reviewing more echoes, but with the aid of machine learning. And what that ends up doing is actually providing greater access to patients. It allows us to have, to read more echoes, or be able to supervise more echoes. And in a way, that's what happened in the radiology world, over here anyway, where radiology has already adopted AI or machine learning, diagnostic algorithms, but they're supervised by radiologists. And there was that very same fear that, they're probably 5 or 10 years ahead of us. And actually what happened was they created more slots and more availability because they could get through more slots. And in fact, then what happened is that there was more diagnostic findings in an appropriate way. Things were caught earlier, and actually it led to needing more radiologists and radiology technicians, because they realized that the demand was there, and they now were able to fill it. So I think basically, I think the similar process will happen with imaging in cardiovascular disease. There is a tremendous need and demand for this imaging modality. And we actually just need we need to be more efficient.
Yeah.
And do more.
We need to be able to provide it, don't we?
Yeah, exactly. There's a huge demand, and it's not just demand, it's a need.
Yeah,
As I said, it's a necessity.
It is.
This imaging modality is a necessity.
It is. I absolutely couldn't agree more. I'm going to try and squeeze a nugget of gold out of you in clinical practice before I go to my final question, Judy. You were obviously co-chair of the 2017 AS guideline, which was a big joint project. you know, AS is something that comes through the door repeatedly in all sorts of forms, can be so simple, can be so bamboozling to assess. What are your nuggets for the jobbing echocardiographer? What must we not forget that will clarify this for us?
Well, I think one of the important statements in the guidelines was that, again, it's so important to integrate and connect the imaging data with the patient. So, and the reason for that is that, you know, our assessment of AS is not perfect. We have three variables that we primarily use: aortic valve area, and the peak and mean gradients are, I think, would be the primary variables. And the issue with that is that they're derived or from basically in different ways. An aortic valve area is a continuity-based equation, but and it's calculated by a number of variables, and that leads to its variability. But the peak and mean is simply a, you know, direct measurement of flow. So there's going to be discordance on some level in those variables, and I think what people don't, you know, what people should remember is that just because a variable is discordant with each other, it's always important to match it with what the patient is presenting with. And part of that is that I think AVAs are inherently underestimates the severity of the valve area. In other words, you always tend to get a lower valve area than may be suggested by the gradients, which are often in the moderate range, where you have a severe aortic valve area. And that may be due to some technical issues that are highlighted in the guidelines. So that's one important factor that I want folks to remember. It's just you have to match it with the patient. And it's they're discordant data, but I think there are technical reasons for it.
Mm. It's so interesting that you pick up on flow, because I think flow is probably, understanding flow is what really pushes you up the next level of practice right the way across the board. I think flow is so important. I have just one final question for you now, just to finish, Judy, if I may. It's been so lovely to talk to you, and I can't wait to see you at conference and have your contribution to our conference this year. Can you tell me who your echo hero is?
Oh, there are so many of them. I mean, if you look at
You can
the
have
history,
two. You can have two.
oh, well, I think what else, the timing is, I'd like to, you know, one of my heroine is Liv Hatley, who, you know, is really a pioneer, a female pioneer in an era where there was obviously, you know, male dominance in science. And I just can't imagine the barriers that she probably went through, the fight for acceptance, and she really, you know, made a tremendous impact in essentially the development of Doppler echocardiography. And I highlight her now because she passed away just June 25th or so. It was actually the Sunday of the ASE. I just wanted to sort of highlight her career and her being such a role model, certainly for me.
Yeah, that's a lovely one to finish on. A wonderful woman, and thank you, Judy, so much for speaking to me today. And we look forward to seeing you in October. The weather won't be good. I'm sorry.
Oh, I'm from Boston. It doesn't matter. I just looking forward to the meeting and visiting your wonderful country.
Thank you. We'll see you there.
Okay, great. Thank you.